30 years of clinical practice have convinced me of something that sounds at first like I'm dismissing you. I'm not. Stay with me. Pain is not the enemy, pain is the message. I'm Dr. Gurpreet Singh Padda. I'm an interventional pain physician. I perform the injections, the ablations, the neuromodulation. So when I tell you that treating pain directly is usually the wrong primary target, understand that I'm arguing against the thing I do for a living. Three ideas hold this together. The signal. Pain is a neurological warning demanding attention. It's an output your brain produces after weighing evidence, not a direct readout from damaged tissue. The terrain. Underneath that signal, something structural or metabolic is out of alignment. Inflammation, poor sleep, mechanical loading your body cannot tolerate, blood sugar chaos, unrelenting stress. The mistake. Treating the signal while leaving the terrain untouched. That mistake is the reason people cycle through pain clinics for years. Every intervention works, briefly, and then the pain returns because nothing about the conditions that generated it has changed. There's a sentence I hear almost daily. My body is breaking down and working against me. I want to replace it, and not as a motivational exercise. The replacement is more accurate. Your nervous system is not attacking you. It is requesting an environmental adaptation. It has detected conditions it judges unsafe, and it is escalating until you respond. So the new sentence is, my nervous system is asking me to change something. That reframe matters clinically, and I'll show you why later in this video, because the language you use about your body measurably affects the pain you experience. Here's what I tell patients who've been told for years that their scans look terrible and there's nothing more to be done. You are not broken. Your discomfort is an entirely accurate physiological response to your current level of inflammation and stress. Given the inputs, the system is producing exactly the output it was designed to produce. It's working correctly. That's not a consolation prize. It's a strategic factor because a system that's functioning correctly with bad inputs is a fundamentally different problem from a system that's broken. The first one you can change. You change the inputs. So where do procedures fit? This is the part I most want patients to understand, and it's the part least often explained. An interventional procedure buys you a window of neurological quiet. The pain comes down. The guarding relaxes. The nervous system stops screaming long enough that you can actually do something. That window is your opportunity. It is not your destination. Inside it, you do three things. You correct movement patterns while you're able to move without provoking a flare. You rebuild your sleep architecture because sleep is when the nervous system recalibrates its threat thresholds, and you implement the systemic changes, diet, stress, activity, that lower the baseline. If you spend the window resting and waiting for the next injection, the pain will come back, not because the procedure failed, because the window was the whole point and it closed unused. Which brings me to an uncomfortable comparison between two models of care. The traditional model, the patient is passive. Appointments repeat. Dependency is sustained. And I'll say the quiet part. There is a business model that profits from helplessness. A patient who returns monthly forever is financially a better patient. The recovery model, daily active participation, measurable progress, sustainable outcomes. You own the result. I want the second one. And I want you to understand that it asks more of you. No system can do this for you. I can create the conditions. I cannot do the reps. One more principle before we close. We reject pain chasing, the endless pursuit of whatever hurts most today. You treat the shoulder, the hip speaks up. You treat the hip, the low back. That's not a series of problems. That's one problem, expressing itself in sequence. Instead, we identify the primary systemic signal, driving the cascade, and resolve that. And this requires something from you. Move out of the victim position and into an analytical one. Ask what specific movements or stressors your brain is actively guarding you against and why. 3 steps. Identify the threat. What motion or context triggers the protective response? Understand the logic. Your brain's protection is rational, even when it's badly miscalibrated. Then retrain the response. Systematically supply evidence that the threat no longer exists. Your brain is not being irrational, it's being out of date. In the next video, why severe pain often means an oversensitive amplifier rather than damaged tissue. Why medication can't fix metabolic debt, and what actually determines whether a procedure holds. Padda Institute Center for Interventional Pain Management, 4477. Woodson Road, Suite 100, St. Louis, Missouri, next to Lambert International Airport. 314-481-5000. This is educational content, not medical advice, and no substitute for evaluation by your own physician.